Welcome to Module 2, an introduction to the basics of functional electrical stimulation. In this training module, we'll go over the basic principles of how FES works. We'll also show you a few scenarios that you'll encounter in the GRAND clinical trial that apply these basic principles of FES. A good starting point is to remember that functional electrical stimulation is intended to activate nerves, not the muscles directly. The application of FES to the nerve creates an action potential that propagates to the neuromuscular junction, which causes a contraction of the muscle fibers, resulting in the generation of muscle force. The goal is to activate the neural pathway that leads to muscle activation, not to try to activate the muscle itself. This ends up being pretty easy to do because the current levels needed to activate nerves are actually much lower than what is needed to activate muscles. In all the examples that we're going to give, we will be talking about activating nerves that innervate the muscles themselves. However, an important consideration is that these effects depend on there being an intact lower motor neuron innervating the muscle of interest. The term innervation describes the scenario where even if the muscle is paralyzed due to spinal cord injury, which damages the upper motor neuron, activation of the muscle is still possible because the lower motor neuron is intact. Successful electrical stimulation requires intact lower motor neurons and muscle fibers. A lot of what we know about the use of electrical stimulation comes from animal studies done decades ago. From these studies, researchers determined that increasing the intensity of stimulation, either the amplitude or pulse width, recruits more neurons. So generally speaking, the higher the intensity setting, the more innervated muscle fibers you may be recruiting, which gives a stronger response. This is called spatial summation. Early studies also demonstrated that increasing the frequency of stimulation pulses activates the same group of neurons but allows individual action potentials to summate, generating greater force. This is called temporal summation. In the examples that follow, the clinician really only has to control two parameters: intensity, which is some combination of amplitude and pulse width and will depend on the type of stimulator used, and frequency, which is how many pulses per second are delivered to the nerve. Frequency is often fixed at a level that causes fused contractions. We're going to go through three scenarios that you'll encounter in the GRAND clinical trial where you will be modulating electrical stimulation and explain what the main theory is for the use of FES at that stage. The scenarios include the stimulated manual muscle test, intraoperative motor point mapping and electrode placement, and post-surgical electrode profiling. The stimulated manual muscle test is done by the therapist as part of the screening process. The purpose of using FES at this stage is to determine whether a paralyzed muscle is innervated or denervated and to assess the strength of muscle contraction. In this scenario, the therapist will use a surface stimulator set to deliver a biphasic waveform, placing the two gel pads near the motor point of the muscle. The therapist will look for the ability of the muscle to generate strong contractions at the maximum stimulation levels. This is a more practical definition of innervation compared to conducting a full electrodiagnostic study. The setting for stimulation intensity is generally higher when using a surface stimulator. Training Module 7 will go into a lot more detail on the process of performing the stimulated manual muscle test. The next point in the study where electrical stimulation is modulated is during the implant procedure when the surgeon performs motor point mapping and electrode placement. Here, the purpose of using FES is to identify the best placement for the electrodes so that they give a nice gradual recruitment of the muscle over a somewhat wide range of pulse widths. This will eventually enable smoother and more functional grasp patterns. During this process, the surgeon will also assess the quality of the muscle contraction in terms of strength and whether other muscles are recruited. In this scenario, the current is applied directly to surgically exposed tissue, with the electrode probe placed directly on the muscle. However, as noted previously, recruitment of the muscle fibers is occurring through the activation of the nerves. To best predict the final outcome, this process should be done under conditions that simulate the current flow pathway in the final implant configuration. So to do this, the surgeon will place the anode near the location where the remote module will be implanted. Because the probe makes direct contact with exposed tissue, the intensity of stimulation is generally set to a relatively low level. Training Module 12 goes into a lot more detail on the process of surgical implantation, including motor point mapping and electrode placement. The next place where modulation of electrical stimulation is performed is the electrode profiling session that is done at the first post-op visit at week 3. Here, the therapist or technician will use a system that communicates with the implant itself to go through each implanted electrode and characterize the muscle's response to stimulation. The therapist or technician will slowly increase the stimulation pulse width until the threshold is reached, and then continue increasing the pulse width to find the setting that gives the strongest contraction. The maximum stimulation setting may be the point of maximum contraction, or it may be a lower value based on the presence of unwanted spillover to other muscles, or because the stimulation causes discomfort or pain to the participant. We go into a lot more detail on electrode profiling in Module 13. There are a few other things to consider about the application of FES generally, and during the GRAND clinical trial specifically. First, it's important to bear in mind that muscle fatigue is a big issue, especially when working with atrophied muscles. During some of the test scenarios, it's possible to tire the muscle to the point that even the best muscle response begins to fade. Adjusting frequency down is one way to reduce fatigue. Another is just to give a rest between activations. Importantly, atrophy from disuse in a muscle with an intact lower motor neuron can be reversed with electrical stimulation over time, which is why during the GRAND clinical trial, participants will undergo a month of exercise prior to functional programming. The main effect of the exercise phase is to improve fatigue resistance. Increasing maximum strength is a secondary effect. And that brings us to a final point, which is that the principles of FES can also be used during programming of the implant for functional grasp. During programming, the basic stimulation settings will be based on the threshold and maximum established during electrode profiling. But in order to optimize outcomes, the therapist or technician will also be able to make fine adjustments to stimulation intensity and frequency. Training Module 13 goes into a lot more detail on how programming of the NNP is done. So to summarize, throughout the GRAND clinical trial, you'll encounter situations where electrical stimulation needs to be modulated for a specific purpose, either to identify denervated muscles, find the best placement for an electrode, characterize the response of an individual electrode, or to refine functional patterns. Each situation uses a specific stimulation technique, but in each case, the same principles of activating neural pathways will apply. Clinicians will follow the same basic rules of changing stimulation intensity to modulate the force of the muscle and changing frequency to optimize force and fatigue resistance. Coming up next in Module 3, we'll go over what kinds of functional outcomes you can expect with an upper extremity neuroprosthesis.